Hey, everybody, welcome back to another episode of Dentistry Unmasked. My name is David Rice, and I'm here as always with,
What's up, everybody? Pam Maragliano-Muniz. David, what's happening?
you know, sun's out, sky's blue. I'm a happy camper right now. You have anything good going by you?
Yeah, it's in the teens and it's freezing in Boston. So,
Oh, sorry. It's like
so
it's Florida cold. It's 60.
okay, you can stop. So, this week is going to be very interesting. We're talking about a topic that, to be completely honest with you, I don't know a ton about. So, I think I'm going to be learning and chatting alongside everybody. Our guest this week is Frank Catalanotto, and we are talking about dental therapy. Frank, welcome.
Welcome. Glad to be here. I should
So,
point out that I woke up to 34 degrees this morning, so
where are you
Ah,
located?
cold for us in Gainesville, Florida. Not for you in Boston.
Yeah, I think I would walk my dogs in a hoodie and not even be thinking about it if it was in the 30s right now.
we don't go outdoors in 30s. That doesn't happen here in Florida.
I have a friend that lives in Savannah, and I guess they hit like 28 or 29 degrees some morning. And he's originally from Massachusetts. So he was like, it was actually funny to watch what the people go outside in.
Yeah.
It is.
It's
It is.
absolutely true.
It is indeed. Indeed.
So, anyway, dental therapy. This is kind of an interesting topic because number one, it's very polarizing and people have a lot of opinions. And I think there's some myths that we need to kind of debunk. So, Frank, would you share a little bit about your background? Because you've done a lot of advocacy on this topic, and you, I think, are the expert, the guy to be talking about this topic with.
Well, but thanks. I've got a lot. I do have a lot of experience with this. So my background is I've been an academic dentist for my entire career. I'm currently at the University of Florida College of Dentistry, where I was the dean for a number of years and then a department chair. And I'm almost retired at this point right now. And I do have to say that the opinions I share do not reflect the official opinions of the university. Um, and I have been concerned about the access issues for many years. I had experiences in my academic career, including working in the slums of Newark, New Jersey, working in Texas and Rio Grande communities with immigrant populations. And there's this dichotomy in this country, the people who can afford to get dental care and the people who can't afford to get dental care. And that number of those who cannot afford is increasing. I mean, we have 70 million people in the United States living in dental health professional shortage areas. As part of the solutions for this, about 20 years ago, I heard about the starting of a dental therapy educational program up in Alaska. And I'd really not heard about this activity before. It sounded very interesting to me. So I wrote to the POCO up there, introduced myself. And before I knew what happened, they flew me up to spend a week. They were so thrilled to have an outside dentist who actually thought he might be able to support this kind of work. And what I saw in that week really impressed me. I saw dental therapy. At this point, they were students in their dental therapy educational program who were performing simple restorative dentistry techniques, as well as my dental students at the University of Florida were performing. I started to become an advocate for this. And over the 20 years, I've watched the progression across the country, where this dental therapy is now authorized in 14 states. I've been to a number of those states where I have provided expert witness testimony because what I did once I saw the Alaska situation, I started reading everything I could about it and learning everything that I could. So we're at this point now where we have 14 states that have authorized dental therapy program. We have dental therapists working in a number of those states. There's been delays in other states for a variety of reasons, but they are successfully working in Alaska, in Minnesota, in Oregon, in Washington, across the country. The bottom line is dental therapy works. And you are right when you said, PM, that this is controversial. The problem is those who oppose it have only one thing. They only have opinion. They don't have any facts to back up their opposition. You'll hear comments like, I can't believe they can do work of this quality. I know how hard it is. Well, that's their opinion. The literature says the quality of care delivered by dental therapists is excellent. So that's what brings us to where we are today. And on a personal level, I've been leading an effort in Florida for 8 years now to pass dental therapy legislation. We think this is the year we're going to get it done. But the opposition of the Florida Dental Association, with their, be honest with you, with their PAC dollars and with their opinions and with their lobbying force, is hard to overcome, but we are overcoming it.
So I have a question. What percentage of dental therapists actually stay in underserved areas treating the population that we're talking about?
That's a great question, and it's underlined by the misinformation about that. There is actually no requirement that they stay and work in underserved areas, but the reality is they do. So if you look at in Minnesota, where we've got now, after the 10 years, about 140 or so dental therapists, virtually all of them work in dental health professional shortage areas in the state. And Minnesota legislation actually requires that 50% of their patients be on Medicaid. So it really doesn't make any difference whether they're in a dental health professional shortage area, as long as 50% of their patients are on Medicaid or otherwise underserved in that state.
So that data is based on the Medicaid percentage as opposed to necessarily a geographic location?
It's based on both. And
On
there
both.
was actually a wonderful webinar last night put on by the CareQuest Institute for Oral Health and the National Partnership for Dental Therapy, where they actually gave out and had a map of those numbers. So during the webinar last night, one of the presenters had a map of the state of Minnesota. Every county that was a dental health professional shortage area was marked in color so that you could see it. And by the way, it was almost every county in the state. And their dental therapists were practicing in all of those counties. So it really doesn't make any difference. One way or the other, they are serving the underserved.
What's the education of a dental therapist?
Well, dental therapists have to go to a school that is accredited by the Commission on Dental Accreditation. That's the same body that accredits dental schools and dental hygiene programs and dental assisting programs. It's 3 years of education after high school. There usually are some prerequisites that one has to take before you get into the program. Some places have done it as 3 academic years. Some institutions like in Alaska and Washington do it in 2 calendar years, where they basically are going to school full time. They take some of the same courses and study the same material that dental students take. They learn basic anatomy and physiology. They sit in preclinical laboratories practicing their psychomotor skills, their hand skills on cutting cavity preparations and how to do restorations. They learn emergency management to the same level and standard. They are limited to working on tribal organizations, so they set their own rules. But in the other states, they then have to pass the exact same licensing examination that dental students have to pass. The difference is it's limited to their scope of practice. So dental therapists, for example, don't do permanent crowns. They don't do implants. They don't do periodontal surgery. They don't do surgical extractions. They don't do bridges. They don't do dentures. They do basic preventive and restorative procedures, single tooth procedures, whether it be amalgam or composite, a pulpotomy, a stainless steel crown. The same level of competency.
So let's talk about that. So underserved community, dental therapist, maybe the only dental healthcare provider for a number of miles. What happens when they run into an issue? Like, I'm lucky because I practice in an area where I can send somebody off to my periodontist or my surgeon, or, something, if something comes up, or endodontist, obviously. What happens when there's an issue?
So the important thing to remember is, first of all, the dental therapist must be employed by a dentist. They cannot set up their own independent practice. And they develop what's called a collaborative practice management agreement, which specifies within their scope what they're allowed to do. So the dentist might say, when you're out of the office or I'm not there, these are the things you can do. When I'm in the office, these are the things you can do that are within your scope.
Mm.
So I like to answer that question with, they would do the same thing that a general dentist might do. Let's say they ran into trouble with a complex extraction. They'd stop the procedure and refer the patient to a specialist for assistance. In that kind of case for a dental therapist, they might call they have telehealth capabilities. They might call their dentist on the phone and say, I'm running into an issue. What should I do? Another great example is a medical emergency. What happens in a medical emergency? The dentist says, let's stop the procedure, starts to stabilize the patient. Assistant, would you call 911 if necessary? Dental therapists would do the same thing. They're trained to the same level of competency in the management of medical emergencies. They know how to handle those kinds of things. So there really has not been any issues in any of the states where dental therapy is being utilized right now that would indicate that there's any concerns about issues like that, Pam.
I think as a dentist, my biggest concern is related to the volume of dentists we graduate. And now we're adding another level of providers. So how do we, because let's be honest, we're graduating more dentists than we need based on where those dentists choose to go live. So, or there wouldn't be an underserved population. We would have plenty of dentists already. So how do we create a symbiotic relationship so we're not graduating people with $500,000 to $800,000 worth of debt who are then, in reality, when it comes to big groups, going to be competing?
Okay. So what I'd like to do with you, David, is debate you on this point.
I love that.
Yes.
I don't know. When we have 7 million people in Florida living in dental health professional shortage areas, you can't tell me that we're graduating enough dentists. I just don't believe it. When we have a dentist population ratio in our state, which is 10 per 100,000 less than the rest of the country, you can't tell me I don't have a dental shortage, dentist shortage in our state. I actually never believed I would say that 10 or 15 years ago. But after living with the data as long as I have, I absolutely do believe it. That's number one. Number two, even if more dentists are not going to solve this problem, you said it yourself, more dentists with $800,000 in debt are not going to want to live in dental health professional shortages in rural areas of the state. They are not going to want to spend a lot of time providing care to Medicaid enrolled patients. Should dentists be afraid of dental therapists? No. Let me tell you what's happening in Minnesota. And again, this is fresh data because I got it last night in the webinar. In the beginning, 10, 11 years ago in Minnesota, very few dentists would hire a dental therapist. They all got hired by safety net organizations. As of last month, 37% of the therapists in Minnesota are now hired by private practice. That's why. It's really quite, and I'm happy for that. But they're also seeing Medicaid patients in that office. Let me share with you an anecdote from a young dentist in northwest rural Minnesota who was with me when I testified in Arizona for the dental therapy legislation. He said, I graduated from dental school. My father wanted me to go into practice with him in an urban area. My wife and I wanted to live in a rural area of the state, northwest Minnesota. I was in practice a year or two. I went out and hired a dental therapist, someone I knew that I had been in dental school with at the University of Minnesota. A couple of years later, I hired an associate dentist, and then we hired a second dental therapist. In my practice, if my patient needs specialty care, they'd have to drive an hour to an hour and a half. My partner and I take all the CE we can. We're providing that specialty care. Who's in the office when I'm out taking a CE course? My dental therapist. My office is still generating income. Last year, he told me in the prior year, he had not done a single one tooth restorative procedure, not a single one. He spent all of his time doing complex dentistry. What does that do to his bottom line? He's making more money. So 37% of the dentists in Minnesota have figured this out. They see dental therapy as a boon to their practice, as a way to help patients, but also make life better for them and their practice. So dentists should not be afraid of dental therapy.
I love that in a rural area. I love a debate too. I love that in a rural area, but I'm just going to use where I live, Tampa.
Yep.
And if Tampa has XYZ group practices that today employ, I don't know, let's say 100 associates, and this becomes a thing, what I know will happen is those big groups will lose some of those associate dentists and replace them with therapists for the very reason you just shared, to become more profitable. That to me is the place where I get hung up, because that will happen if we don't have guide rails for it.
Well, we hopefully will have guide rails for that. We've not seen a big DSO employment of dental therapists in Minnesota at this point. Most of them are actually going into private practices. A lot of DSOs do not take Medicaid, and therefore would not necessarily want to hire dental therapists if they have to provide care to Medicaid patients. So I'm going to say something that's going to sound very unsympathetic to dentists, but my concern, dentist colleagues and friends are going to survive. They're going to do just fine. Okay. They may have to think about relocating. They may have to think about changing their practice model, but they're going to do just fine. All right. I'm thinking about the fact that in Florida, as an example, CareQuest has given us data to show that we have the lowest percentage of children getting dental care in the United States, in our state of Florida. This is ludicrous. Do you know the impact of poor oral health in children on their school performance and school attendance? And that's going to affect their economic status later on in life when they try to get a job. On their emotion, this paper's on their impact on their emotional development. No, the impact of periodontal disease on systemic health, cardiovascular disease, and diabetes. Those are the people here more affordable and accessible for those patients. And my dentist colleagues will do just fine. They may have to change their practice model, but they're going to do just fine.
Well, I have a question. So is that a caveat with dental therapists that they have to treat underserved people or they have to accept Medicaid and state insurance? Is that a thing? Or,
So
if it happened in Massachusetts, I could just hire a dental therapist almost as an associate.
yeah. So I'd like to say that that was a rule in every state, but it's not. I would like to see that provision. It is in Minnesota and a couple of other states, and it is not in the Florida legislation. That may change as we get closer to passing this legislation, but it is not a requirement. I can live with that because I am convinced of the ultimate long-term beneficial effect.
I don't know if this is a fair question, if there's an obvious, easy answer with this, but how many malpractice claims come across the desk regarding dental therapists versus dentists?
As of last night's webinar, 0 for dental therapists after 11 and 12 years in Minnesota. That's the state where we have the best data. The malpractice insurance for dental therapists is $80. There have been no claims. There have been, I take that back. There have been 1 or 2 issues raised, all adjudicated as no problem. It was, not malpractice, okay? And I said, these dental insurance companies are not stupid. They know what the risk is for dental therapists. The risk is very, very low. The risk comes when you are doing complex procedures. There is virtually no risk for single tooth restorations and preventive care.
So if something were to happen and I'm almost imagining the relationship similar to that of an associate dentist or almost a hygienist, where if something did happen and somebody were to sue, I'm thinking they would go after the practice and not necessarily the individual. So like that's kind of where I'm wondering if that's why there's such a price differential versus the risk differential.
So that very well may be true, except for the fact that we've had no claims in 12 years. And also, it's a different mechanism. The Alaska program, where we also have 16 years of history, they go before a federal board as opposed to a board of dentistry. And again, no claims in the 15 years in Alaska. So at some point tomorrow, might there be an issue with a dental therapist? Of course, right? But as of now, the data only attests to high quality, safety, cost effectiveness. It's unequivocal.
What is this might be an odd question to ask, but I'm thinking along the lines of medicine and where physicians assistants have come from, right? They started off in one role, and today I hope my cousin's, maybe I'm hoping she's not listening, but she's a, a PA for a plastic surgery rifling Botox all day. So
Yeah.
I love you, Lindsay, but that doesn't count. What does the average pay scale look like for this position?
So it's hard to get clear data on that. More than a dental hygienist and less than a dentist is the best way that I could answer you. Somewhere in between a dental hygienist and a dentist. It's very, very hard to get very clear data on that. The American Dental Therapy Association has tried to get some data. I've tried to get some data. There was one survey in Minnesota, but that's Minnesota. It's going to be different in every state, depending
Sure.
on the competition level and depending on the perceived value. The analogy to PAs and ARNPs is legitimate to me. And I know in particular, the PAs have gone into a lot of specialty care. But if we look at the ARNPs, a lot of them are in true primary care.
So where do you see dental therapy going? Do you see the ADA and other dentists continually fighting this just indefinitely, or do you think dental therapy will become the PAs of dentistry?
I think dental therapy is going to become a real thing shortly. Let me tell you, this webinar last night that I mentioned, 1,400 people signed up for this webinar last night across the country. 1,400. To me, that shows you the level of interest in this. The other thing that I think might happen is that this is what's happened in other states. So when the Dental Association sees it's actually going to pass, they're going to come to the negotiating table. And then they're either going to stand neutral or say they're in support of it. And we've seen examples of both of those in several states that recently passed dental therapy legislation. Once dentists understand the model and how it can be helpful to their practice, a single person or a two-person dental practice, the overhead is enormous, absolutely enormous. What if you can share that overhead by keeping your office open for some patients on Saturdays and Sundays, evenings? The value of having a dental therapist in your office is critical. And imagine if we're short of providers now, what happens when there's a dental benefit in Medicare? And all those millions of seniors all of a sudden get dental insurance and want care. Where's it going to come from?
Then I'm going to say dentistry is an entirely different profession on so many levels.
Yeah.
On so many levels. And I will be grateful that I'm on the tail end of my career.
David, we're a profession that is used to fixing things. We're not a profession that is based on preventing problems. All right. We get patients healthy. That's the mindset that has to change in our profession. And so dental therapists are trained just like dentists for the fixing part, but they're trained much better than dentists for the prevention part. Dental therapists are strong advocates for minimally invasive dentistry. Dental therapists get really strong training in motivational interviewing, how to change patients' behavior. We don't do that for our dental students. Prevention is just something you got to do, but it's not our hands. What we do with our hands is what's important to most dentists.
No,
That's not a criticism. That's how
yeah.
we train them.
Well, so I entirely agree with that point. To me, a large part of this is the flaw in the academic
Yep.
environment that is dental school for the last 15 years, maybe longer, is we're not training our students well enough at all. I mean, there should be a plethora of patients at every school if we treat the Medicaid population. Um, but every student graduates having done 2 root canals, and if they're lucky, they've done a couple crowns and a bridge. And to your point, they get no experience with emotional interviewing. They get no experience in case acceptance and patient communication. And it's the system is broken for sure.
So I've been in academics my entire career. All right, I've been a dean. I've been a department chair. I tried to introduce a strong motivational interviewing curriculum into the college at the University of Florida, and we were successful for about 4 or 5 years, and it's just sort of dissipated away. There's so much we have to teach. I was on department chair. I tried to bring in a motivational interviewing course, a stronger course for our dental students. And it lasted as long as we had some grant support, and it's just sort of dissipated away. There's just so much to teach in dental school, and not enough time. And I had been an advocate for a required residency year after graduation, similar to medicine, for many years, as a way to help deal with that issue.
No, I think you're 100% correct on that. And I feel like it's just time to revamp dental school and admit there is a lot to learn. But on the flip side, if you're sharing that we can have success with people in a 3-year program out of high school, then maybe we just need to unplug a lot of things dental school teaches, get stronger in our mandate of continuing education, and that could help us with dental school education, kind of aside from today's topic, but we definitely need radical change.
We need change. I would not agree with you. I would not recommend diluting dental education. It's necessary to have leaders of the team that have the skill set that dentists should have with all the education they have. And again, I'd remind you that it's not 3 years after high school. There's usually some prerequisites that they take. I want to just make sure we keep our facts straight, David, for our audience. But I appreciate the sentiment. We need to do something differently. I'm not sure what it is. I think a required general dentistry year is better because the feds will pick up a lot of the tab for that through graduate medical education funding. And it's also a way to help address the access problem because you can place a lot of those residencies in underserved areas of the country.
I would totally agree. If you gave the average dental student slash new grad a program with the government that heavily impacted the student debt that they had, they would give 2 years in underserved areas.
Absolutely, without it.
Yeah, I want to bring up the education piece one more time because
Sure.
I was a hygienist before I became a dentist, and I have my associate's and my bachelor's degree in dental hygiene. And so, dental hygiene, an associate's program, is 2 years. There's no way you're doing that in 2 years. You basically, just like you're describing, you have to have prerequisites ahead of time, and it's not even like if you're doing the bare minimum, you maybe could get those prerequisites done in a year. Is dental therapy considered like an allied health program as an associate's degree? And these prerequisites, is this a community college type thing? Like, where are you getting education?
So each state is a little different because of the way it got legislated and the laws passed. Minnesota actually requires a master's degree. We're planning on probably a bachelor's degree in Florida. In other words, a couple of years of some prerequisites and then a 2-year full-time or 3 academic year program. Oregon, Washington and Alaska do a 2-year program, again, approved by CODA. There are some prerequisites. There's not a lot, and they've been successful. So you can't argue with success. You can hypothesize that this shouldn't work, but you have to go with the facts. The facts say it's working. It's working.
Yeah.
Yeah. I mean,
I think
again, there's lots of opinion, and I respect opinions, but my academic career was mostly in research. I mean, I've got 130 publications. I've had in the last few years, I've had $11 million in research grants in my career since I moved to Florida. I believe in data. That's what convinces me. Opinions need to be listened to and discussed, but data is what convinces me that something is correct or not correct.
I would agree with that.
With you. Yeah, I
I would agree
agree.
with that.
I agree. And I feel like obviously I believe wholeheartedly that people need to be cared for regardless of what they can and can't afford. I also believe, since, this is our podcast, I guess I can share my own beliefs. I feel like, if the pay scale is better than a hygienist, less than a dentist, the education is almost like sort of less than hygiene, less than dentistry. I feel like it should fit into that. I mean, like I like compartments and I like things to kind of, fit into a mold. And I feel like, if you're going to, aspire to be a dental assistant, this is the training, this is what you do. And it makes sense that you make less than a dental hygienist. And a dental hygienist has this level of training and this is what you do and this is the compensation that you get. And then dental therapy is in this weird gray area. And for me, I feel like it would work in my brain a little bit better if it was compartmentalized, kind of, where it fit, where where the different roles in dentistry exist currently, because that's not going to change.
No, I understand, but again, I would not want to minimize and say it's less education than dental hygienists. It's different education. I mean, so dental therapists, for example, cannot do soft tissue curettage. They don't do procedures like that. That's not what they're trained to do. They do supragingival scaling, and that's it.
Oh, don't even go there with me. Super gingival. I have like no use for that in my whole life. But no,
So does my oral B.
No, I just feel like, yeah, no, it's interesting. And I think that, all right, let's talk about this. I think that whether you agree with it, you disagree with it, I think we all could use more education on it. And so where can we learn more? Where can we, do some of our own research so we really can have not only have an opinion, have an educated opinion?
So if you go to the website for the National Partnership for Dental Therapy, they have a vast amount of resources. If you go to the National Coalition of Dentists for Health Equity, they have a pretty good resource list, but the National Partnership has a terrific one. If you go to Floridians for Dental Access, my coalition, we have a big resource page. And those are really the three key sources of information where you can learn more about dental therapy. But again, I have to repeat this over. The data is on my side. And I respect people having an opinion, but the data is on my side, and we've got to do something for these people who are in need. Let me tell you another brief anecdote. Last month, we got major backing from a medical insurer in Florida. Why? This is going to save them money. The literature on the oral health systemic health relationship is incredibly strong now. All right? You will save money in the medical end and improve patients' health if you can help prevent periodontal disease. It's very clear. All right. So that's why this company is willing to support our efforts to get this passed in Florida. It just makes economic sense to them, let alone the personal impact on people's lives.
I have to tell you, this is one of my favorite conversations we've had in a while. I love, I feel like we can have really productive conversations. There's a lot to be learned, Pam, like you said, on both sides of this thing. So I really appreciate you being here today.
Well, I appreciate the opportunity to talk with you. But then again, I apologize for the internet connections. Nothing I can do about that.
Pam, you want to take us home?
Absolutely. Well, Frank, again, thank you so much for your time and for your candor and for fielding all of our questions. This was absolutely fantastic. And friends, thank you so much for joining us for this week's Dentistry Unmasked. And we can't wait to see you all next week. Have a good one.
Thank you very much. Take care. Bye.
Bye, gang. Thank you, everyone, for watching or listening to the show this week. And thanks to our guests and sponsors on this episode.
Please check out our social media at Dr. Pamela_Maragliano and at Dental Economics Official.
Or you can check me out at igniteDDS or at Dr. David Rice.
And go to dentaleconomics.com to receive dental economics. You can choose to receive DE in print or digitally, and you can also get the details of our Principles of Practice Management conference on our website.
If you have topics or guests or anything you'd like to talk about on the show, send us an email to dentistryunmaskedpodcast@gmail.com, and we will do our very best to make it happen. Thanks again, and we'll see you next week.